Well, good morning, everyone. Welcome to our panel discussion today. I'm a health reporter for CNN. My name's Jacqueline Howard, and I'm so excited to welcome you to our discussion titled How to Decipher Health Information. I'm joined by a panel of esteemed experts in healthcare, data science, and journalism. Let me first introduce Stephanie Ilgenfritz, coverage chief for health and science at the Wall Street Journal. Welcome, Stephanie. And next, Garth Graham, global head of healthcare and public health at Google and YouTube. Welcome, Garth. And Poppy McDonald, president of USA Facts. Now, this panel's topic, how to decipher health information, it really couldn't be more timely. The impact of misinformation and disinformation is being discussed across a broad spectrum of areas, so much so the World Economic Forum has identified misinformation and disinformation as the leading short-term risk facing the world today. So our goal in today's panel is to take a deep dive into where health information fits into that conversation. With various information sources literally at our fingertips, we are more connected than ever. We have greater access to information, but how do we decipher credible information and what is not? And the challenge will grow even more powerful as technology advances. And before we start our discussion, just to give a glimpse into what we know about how many people are turning to online sources for health information, I found a survey conducted last year by Healthline and YouGov. And this survey asked more than 4,000 respondents here in the US about the various health and wellness tools, resources, trends, or products that they use, and where they learned about these different tools and products. So the survey found that among the respondents, more than half, 52%, said they found their health information about these tools and resources on social media. More than half. 37% said they found them using an online search engine. About a third, 34%, said they obtained the information from their doctor or their healthcare provider. And then 32% referred to their friends and family. 30% used a health information website. So with that as a backdrop, while these sources and social media may appear to be the dominant source of information, how much trust do people have in these sources, and how can we help people identify reliable sources so that they can make informed healthcare decisions? That's the conversation we're going to have today. So I'd love to open up these questions to the panel. I'll first start, Stephanie, with this conversation. We often hear the terms used, misinformation and disinformation. Can we start by exploring what these terms mean, if anything, and how do you use them in conversations?
Yeah, I think it's a tricky question to answer in a lot of ways, because the words mean different things to different people. I think you have to keep in mind that one person's misinformation is another person's deeply held belief, and another person's source of fear and confusion. So I think that's an important thing to consider. There are obviously objectively false information out there. There are things that are provably false. Scientists who will alter their papers in order to get published, and then that work gets built on. There are falsehoods out there that are provably false, like that COVID vaccines killed more people than COVID itself. But we also have to consider the perspectives of people when they think about the information that they're getting. I'll give you an example and I'm not coming down on one side or the other on this, but there's research out there on gender dysphoria. And physicians rely on this research to treat trans people, and to them that is vital, important, true information. But there is a whole cohort of people out there to whom that is the definition of misinformation. That anything that suggests that anything not besides binary man and woman is pernicious misinformation. And I think one thing we have to consider is that, and come to grips with, is that we'll never have complete agreement in society on what is misinformation. And that's a real challenge for all of us.
And it's such a challenge considering, like you said, we will never have complete agreement on what is misinformation. So then what is needed to help people identify misinformation if we don't have complete agreement on what that is? I'll start with you, Garth, on that. What do you think is needed to help
Right.
people?
So I bring a lot of thoughts to this from a different perspective, not just in my role at Google, but I'm also a practicing physician. And have been through the old times when doctors were afraid of Dr. Google. And I remember, as a clinician, you would always be like, oh my gosh, I can't believe my patient came in here with all these questions of information they found online. Now I love when my patients do that. Because now they've empowered themselves with their own set of thoughts and ideas from information they've gathered. 2 points I'll make on this and then go to another point in your question is, when was the last time you went to, Encyclopedia Britannica or, some paper source of information for what you need? If you want to fix your fridge isn't working, and you're worried, you don't go, man, I got to find that manual. And if I don't find that manual, I am not going to look this up, whatever I'm going to do, until I can get in touch with the manufacturer. It doesn't work like that anymore. People want to engage in information, empower themselves, and make their own decisions. So as a clinician, coming to terms with that has been both empowering for myself, but also then has informed my role in terms of what we're doing at Google and how we empower people with the right kinds of information that meet their needs. And so I think the crux of this really is meeting people where they are, understanding the cultural context of the information that they're going to receive, and making the information relevant to them. If it is a lecture, and if it is a esoteric concept that people don't understand, even if it's life-saving to them, they may not see it as important. So the real concept here is how do you make information both relevant, meaningful, and then certainly we want to make sure that we're delivering evidence-based information in that context. So that's how I think of the importance of health information, particularly for individual patients. And to that earlier point, I love what you said before. Southwell is a researcher out at RTI. He brought up that he makes the same point you do, which is try not to demonize people you disagree with. Because what you believe and what somebody else believes, they may differ, but once you demonize the concepts, then you create a gulf in terms of making that conversation. So as a clinician, when I encounter a patient that has a different experience or a different concept, I have to engage them where they are and understand their belief system and then converse with them in that context. So all of that's important for saying that information is a determinant of health, but it's important that we understand the context of that information.
And to follow up on the work that you do at YouTube and Google, I would love to learn more about what steps those platforms are taking to help point users to trusted sources of information.
Yeah, so this has been a fascinating journey for me. We do a number of things to really, again, try to point people to evidence-based, credible source of information. And so I'll try to truncate this and be brief, but we work with the National Academy of Medicine to develop a series of concepts around what constitutes a credible source of information. And then we've ingested that into our systems. And right now, if you go to YouTube and you search for any health topic, you'll see a label that pops up that says this is from an accredited hospital, this is from an accredited government entity, this is from a licensed physician, this is from a licensed family therapist. And the idea there is that it's important for people to understand the credentials and the cues and clues that they're looking for to digest health information. So that's one of the steps. What's been fascinating to me about this is doing this around the world. Not just in the US, but seeing how it's grown in the UK and in France with the French Order of Physicians, in Indonesia, in India, where these concepts help to really crystallize where people can trust sources of information. But to your earlier point, though, it has to be meeting them where they are. And that's really the crux of effective communication.
And Poppy, I'm curious your thoughts on what you think might be needed today to help point people to trusted sources of information, especially at USA Facts. I understand that you are leaving the organization at the end of the month. So this is kind of the legacy that you are leaving. I'm curious to hear the work being done at USA Facts and your take on this.
Thank you. Yeah, it's been an incredible 7-year run. And our mission at USA Facts is to empower Americans with the facts, because we believe they deserve to have a trusted, transparent source of information. And when we asked Americans in our State of the Facts poll, are you able to identify, is information factual, only about 36% of Americans felt confident that they could do that. And when we asked them, how would you know if it's factual, 62% said if it was rooted in data, and 75% said we wanted to know what is the source for that information. So I love, Garth, how you talk about providing what is the source of that trusted information. So that sounds easy, great. We just need to have trusted data, and we need to make it accessible. Misinformation in the case of health can be life or death, and USA Facts found that in COVID. People were saying, we don't know how this is spreading in our county. Where do we go for that information? And there are 3,144 counties in the United States. There is no pipeline for counties to report data to their state, to report data to the federal government. And so people were left without that information. USA Facts stepped in, and we collected that data every day. It was difficult. In some cases, we were just scraping it off of a publicly available website, but in some cases, we were going to a sheriff's Facebook page where that sheriff was giving that update. And so I would say it is concerning, right, to be in the United States of America where the data is the people's data. It's technically publicly available, but it's very hard to get. So that's why our work is really grounded in bringing that data together and making it accessible to the public.
I'd like to add one more point about the idea of trying to figure out what are the reliable sources of information. And one thing I would encourage people to think about is to consider your source, to your point. Who is this person getting information? We know that a lot of young people especially get information from social media, the influencers on TikTok. So consider who are the sources of information. These influencers are often paid to promote products. They may be promoting a point of view or but it's not grounded in science at all because they are paid to do it. What if the information that you are looking at is from an advocate, a consumer advocate, perhaps a well-meaning one, or a political advocate of some sort? They may be providing data to support what they're telling you, but they may not be providing all of it because they have a point of view, and they may not be, looking at the whole universe of data. So you want to really consider your source, and are they being transparent about where they're getting their information to both of your points.
Stephanie, when we think about sources, I am curious, as a journalist, we both work to combat misinformation, but we are working today at a time when there has been mistrust of the media. I'm curious how you approach your work, and how would you say we can continue to combat misinformation when maybe our audience may not even trust us as journalists?
Yeah, that's kind of disheartening at times because we feel, as journalists, we work very, very hard to be fair and to include all points of view in the proper balance. And to not feel trusted knowing how hard we work can sometimes be a little disheartening, but I think that what we need to do is listen to our audience, respect our audience, understand, as we've been saying, I think now a theme is emerging here, meet them where they are and where they come from and understand their needs. I think we saw, particularly during the pandemic, that a lot of people who had questions about healthcare information felt dismissed and belittled because of the questions that they had. And we have to actually really listen to what they are questioning. What are they interested in? What do they wonder about? What are they confused about? Our job is to help them figure out what they can take away from this vast, confusing ocean of information out there. So we have to, in stories, acknowledge what are these other concerns, have respect for it. Why are there doubts about this, the conclusions of this paper or the findings of an institution? Why are there doubts about it? And acknowledge those and respect those because they come from a very real place. But that does not mean, and I would caution that we have what we call false balance. Not every piece of evidence has equal merit. We acknowledge what one point of view might be and why, but our job isn't to just be completely and utterly neutral and say, well, some people say this, some people say that, you figure it out. People are coming to us actually to cut through that. And so we need to provide some kind of takeaway that the weight of evidence suggests this. These are some other very, very valid concerns that many of you may have, but this is what the preponderance of evidence suggests. And we have a saying at the Journal that's kind of our mantra about being audience first. And it may seem a little obvious to consider your audience first, but that wasn't necessarily always true in mainstream media. Once upon a time, we were a lot more paternalistic. Your dear little reader, this is the information that you need, and this is what we're telling you need to know. And we've actually kind of had to flip that on its head, and it's been a journey to really think about the audience first.
Let me dovetail that concept of trust, because it extends beyond the media, and you certainly see trust shifting in a lot of different ways now. And it's important, again, to kind of recognize where people are. So I am Jamaican, very Jamaican. And my best friend is Rastafarian and has a lot of different belief systems than I do with all my education around health. And we often sit in debate many times. And my degree does not earn trust in many communities by default. The concept, what is more important is, am I empathetic? Am I engaging? When I go back home, when I go back home to either Jamaica or the Pork and Beans Project where I was raised, I engage with my community and understand where some of those fault lines lie. And so it's really important, to the point that you just made around this idea of understanding the concepts, understanding the narratives, and recognizing, listen, it's great to be in the mountains of Aspen. We're all really smart, great, probably sometimes attractive people. And we all have meaningful pieces of information, but what does that mean to the community? What does that mean to individuals in the community? And what they really want to know is not that we're smart and great and have a lot of degrees. They want to know, are you empathetic? Do you understand my plight? Do you understand me? And it's this whole concept of really earning people's trust. So I would say it goes beyond the media. It goes into clinical care. It goes into production of health information. It's all about this idea of, I think, empathy and gaining trust, not just assuming that that you have it.
And Jacqueline, I would just add, too, that when we think about empathy for people, right, they are getting so many sources of information, and it can be competing. You can hear the incumbent politician say everything's going really well, and the person running against them saying everything's a disaster. And so our hope really is, if we can ground in the data, if we can say these are the facts, both sides can agree, and then a healthy debate can go from there. And so that's what we do at USA Facts, is we bring the data together on relevant, timely topics and say, here are the numbers, you decide for yourself. And we think it's working. We add Fontes, who looks at media sources, kind of all media in the country, has ranked us the most credible and least biased. And I think it is that grounding in the data. And we hope, obviously, it's hard to get the data, so by making it more accessible, we hope that journalists, that politicians, that community leaders can ground in those numbers and then let a healthy debate go from there.
When we think about sources of data, I'm also curious, though, we are having this conversation at a time where we're seeing some funding being rescinded for sources like at CDC and NIH. So at a moment where sometimes we may see those data sources coming to an end for certain programs or certain populations, how will those gaps be filled, do you anticipate? And what may be an outcome of seeing some data sources potentially coming to an end?
I could start, I guess. So I think it's not entirely clear yet how much data might really be disappearing or halting. There's been cuts at agencies like CDC that gather information, but it seems to be more of a thinning of the ranks rather than wholesale cuts. Some things have already even been reinstated, so I don't think we're completely clear yet if we're going to really see sources of data come to an end. But it is really, having reliable public health information, longitudinal public health information on deaths and disease and how healthcare is paid for is vitally important. Certainly we rely on that as journalists to help us understand the world and figure out where there are issues that we need to look at going forward. It's important. Where that might go, and I think Poppy probably has a lot to say about this, there might be some private sources, private entities that might step in. I don't know how great if that's a permanent solution, because I think if too many private entities step in and say, well, we'll take care of this, then perhaps the federal government might ultimately say, well, obviously we don't need to do this at all. But there have been times where private entities have been super helpful, like what Poppy was describing during COVID. And I recall that we, all of us in the media, looked very closely at the information coming out of Johns Hopkins because it was so hard to track the COVID virus across all of these public health entities. You know, it's very spotty, and they had taken upon themselves, similarly to what you're describing, to scrape every local website and put together a comprehensive, to the extent that there could be such a thing, resource for COVID. And then when that need was no longer there, they wound down. And we're back to the relying on the federal government and the local, state and local governments for the most part. I do hope that we don't see what a lot of people are worried about. I do hope that that does continue.
Yeah, I agree with Stephanie. We don't know yet, but we do know even with full funding, even when CDC and NIH were fully funded, there were data gaps. So as you spoke about, we didn't have reliable COVID data from counties. Johns Hopkins, I think a few other entities, including USA Facts, stepped in to collect that data. But we shouldn't have little USA Facts being the official source to the CDC and the White House for COVID data in this country. We think it's really important that government be that reliable resource. It's collected by civil servants who exist across political administrations, and it's funded by the people. It's the people's data, and we should have access to it. So I think it's really important that data continue. USA Facts doesn't advocate for any policy positions. We just provide the data, but we will advocate for open, accessible public data. And so as we've seen cuts in funding or staff, we've continued to be open and public about the fact that data must continue to be a resource for the public.
And as we think about, the future of data sources, I am curious, Garth, I'll ask you this. How do you anticipate artificial intelligence may play a role in what we see in the future? We already are seeing AI, play a role currently and shift public access to data. But what do you predict some advances in the future may look like?
Yeah, I think AI has the obvious potential of helping to, simplify and get people access to data in a simplified manner by being aggregated and give it to someone in a way in which they're asking a particular question. So I think there's a lot of opportunity, potential opportunity to AI. Clearly, we all know that this comes with challenges and concepts around responsibility, and how do we continue to teach communities to get data from multiple sources, understand, again, how do you verify and check, and then be able to also think through what does that mean for you. So I think there are clearly some opportunities in terms of data access and simplification. I'll tell you one thing. I often, I had when I was in academic world and publishing data, we used to have this cohort that we'd follow, this diabetic cohort that was based in a church. And it was interesting how little many of those folks who suffered from the complications from diabetes understood all of the emerging data around diabetes, which was exciting. We had, all these things, and it really just boiled down to them understanding, what does my hemoglobin A1C mean for me? Because they needed something to act on. So one of the concepts we have to think through as we go through this moment, not just with AI, but understanding the moving parts of data, is it has to be not only accessible, but in a format that people can have action and move on. And I think that particular step is where that next step we need to go in terms of understanding the importance of data.
It sounds like you're saying data can be used to empower patients, empower the public. When we think about going back to AI, though, and I am just so kind of excited to see how AI could be used to empower people. But when you mention challenges, there's also the worry that AI could spread misinformation. What balance do you think is needed there? And what risk-benefit profile do you personally see AI as having?
Yeah, I mean, I think that's what I was trying to allude to before. I think there are obvious benefits and obvious risks, and we have to be responsible around the risks as we try to take advantage of the benefits. So clearly, the idea of false information, deep fakes, the kinds of things that may be misleading is particularly important. On the Google end, we've been very deliberate about the kind of misinformation, the kind of trust and safety policies we have, and removing information when it's generated by AI that may lead to harm in individuals. And that's just one aspect of thinking this through responsibly. But I think the thing that I always go back to in different threads of this conversation is empowering people. And so we have to think through how do we empower individuals and communities to be able to understand the information they're accessing and be able to differentiate different sources and be able to understand the concept. So a lot of this is about empowering communities, but again, we really have to be very realistic and very thoughtful about what the risks are as well.
I think it's, oh, sorry.
You go ahead, Stephanie.
I think what you're saying is so important that individuals have to be able to understand what these things that they hear about AI mean in their own individual lives. Yeah. And I'll just kind of make a sort of related and tangential point about AI that I find particularly interesting is that it works on both sides. It can help generate, it could be used to generate pernicious misinformation, but it can also read out misinformation. One of my favorite kind of use cases in this is in medical and scientific journals, there are a lot of journals that struggle with fake papers that are generated by paper mills, which are places where researchers can pay to get a paper generated because they're under pressure to publish or perish, and they for money, these paper mills will generate papers that have been made by pulling from other people's papers. There's plagiarism, they make up authors, they combine different kinds of authors to come up with like some fake paper, and some journals have been really inundated with it. So the journals have at times used AI to weed out those fake papers and find those patterns and shut them down. So what you're kind of looking at, I think, in the future is a sort of bot versus bot kind of situation in AI, and whoever has the mightier algorithm will win. Perhaps Google is working on that.
And I'll just say on AI, we think there is enormous potential, but we have a long way to go. And I'd say the first piece is on public's trust of AI. About 64% of people in our State of Facts poll said they don't trust AI, and over 50% said it gives unreliable answers. And I think there's a good reason for that, which is LLMs are not great at reading data, and we've found that personally. It seems so exciting. Like, let's just put an LLM on top of all of this amazing government data, and we were getting a correct response 18% of the time. So as an organization that says we're giving you accurate facts, obviously we couldn't just let LLMs run loose on a government data set. And so we're doing that in two ways. In the short term, we have a human in the loop at all times. And Stephanie mentioned making it personal. That's what's incredible. We can't have, well, we could, but it would take a lot of humans to write individual stories, taking data and making it relevant to people based on where they live. But we can use an LLM to scale that. So depending on the county you're in, or your zip code, or your demographic, we can give you a correct answer, but we have a human in the loop to ensure that that's the case. The other thing we're doing is partnering with government. So we're working with the Department of Commerce to help them think about how to set standards for how government data should be structured so that LLMs can not only read that data, so it's machine readable, but it's also understandable. And our hope is that if government can start publishing that data in that way, that AI can become much more reliable at delivering correct answers.
No, I'll just add on one point to this concept of data reliable information in general. One of the personal and professional journeys I've been on is I spent a lot of time publishing papers, and I enjoyed it, loved, oh my gosh, p-value was great, the Kaplan-Meier curves, oh, wonderful. I would go and give talks and give speeches and give presentations. And I realized the limited input that was having back in the places where people I care about. And so this concept of translating data outside of journals, outside of places where data is connected, and into living rooms, into kitchens, into sitting on the stoop, into people walking with their friends and wondering what to do now that they have breast cancer, or they heard that the doctor say the C word. And what does this mean? That's the power of data. And so when we think through all of these concepts, I think we have to envision a world where we've translated these ideas not just into, again, going back to just what I was saying about my old life, of where we value publications for scientific concepts, but we value publications for community impact. And that is where you go through this whole arc of data, data access, data distribution, engagement, people, and impact. And so we have to think through that full arc, and that's where this whole idea of even what we're talking about, where you started this conversation about health information online, starts to take a lot of meaning for me.
When we think about community impact, I would like to ask each of you, I know that you each shared the work that you all have done, but are there any other examples that come to mind when you think about meeting people where they are, and who has done that right? Or has there been an instance where you have seen that done right, where we have met people where they are with empathy, empowered our audience, and we saw positive public health outcomes? Do any of you have any examples?
That is a tall order, but I'd like to hear what your, what your answer is.
In fact, I think that example is somewhere in the audience, although I don't see her right now. There's a lady by the name of, a doctor by the name of Lisa Fitzpatrick, who... Oh, there you are. Yeah, yes, I knew I saw you when we were walking by. Lisa has created a program called Doctor on the Street, and it's been going on for many, many years. And she goes out into the community and she talks with people, elderly people, young people, and she talks to them about pertinent scientific issues, macro issues, but also specific clinical community issues. And when you watch some of that information, you start to understand where communities are with information. And then she feeds this back up through a lot of different partnerships to be able to try to take this to scale with plans and with others. And I think this whole, it's a hard job. And so, shout out to her for being the lead, taking on the leadership in doing that. But this whole idea of really meeting people where they are, I think has to be part of the calculus, has to be a part of the equation when we think through, what we deem as success.
I'll highlight another example that I love in terms of meeting people where they are and bringing health solutions to them. There's an organization called Eat Real. Nora Latour runs it. And her goal is looking at rising obesity, rising diabetes. Let's start with early interventions with children, and let's go with where they get their primary meal of the day oftentimes, which is in our schools. And so she goes into public schools and helps think about how do we bring in locally sourced organic food, how do we create nutritious, delicious meals, and really set kids up right, and going right to public schools. I love that example.
And then I'm curious, well, Stephanie, I wanted to ask your thoughts. When you think about the media landscape, and we already talked about how we're seeing trust shift, but when we think about the role that journalists play today, when it comes to health information and combating the spread of misinformation, how can journalists really focus on meeting an audience that is getting their news on social media, that is no longer, most people are no longer sitting down and consuming the same evening news that everyone in their community is consuming? So how would you say that journalists and other communicators can meet people where they are?
Yeah, it's a challenge, and we think about it in a couple of ways. Obviously, we need to be on the platforms where everybody is actually consuming information. If anybody here has a teenager, where do they get their information? It's like TikTok. Everything is right there on their hand. So we have we're online first. The Dead Tree print version is kind of an afterthought at this point, but we definitely focus on online. But when we are on platforms that reach people in different ways with different audiences, like video and social media and podcasts on audio, one thing we always keep within our field of vision is that the standards are the same for journalism, no matter what the platform is. The standards apply to a podcast and to a video in terms of the rigors of our journalism, the broad sourcing that we do, the deep reporting that we do, the transparency in terms of our sources of information. The standards are no different for a podcast or even for like a TikTok, which we actually do at the Wall Street Journal, than they are for the papers on the stories that go on the front page of the Dead Tree version. But also, in terms of our overall approach, thinking about audience first, but also thinking about what you were talking about, getting down to like the individual people and how are they going to understand how this relates to them. We think a lot about the people in our stories. We do. I in my own team do a lot of investigations that are based on data. I love data. We look at big data sets and we write all this SQL code. Not bots do it, actual people do it, to pull findings out of this data. But those are just statistics until you put the face to it. And that's one of the things that I think is really, really important in communicating healthcare information in a way that individual people will find relatable. Like, the number of homeless people on the street with schizophrenia is just a statistic until you can put a face on it, which we did in a series last year. We wrote a number of stories about a man named Rob Dart, who was a lawyer, successful career, but he later struggled with mental illness, was lost to care during the pandemic, disappeared, his family couldn't find him. Our reporter found him on the street and wrote a series of stories about his journey and his family, and that illuminated an issue that otherwise is just a statistic, like how an individual death is a tragedy and thousands of deaths are a statistic. When you think about the homeless population, it feels like a dry statistic, but when you put a face on it, people can relate to it.
By the way, that was a wonderful series.
Oh, well.
Yeah, I loved it. Sorry, I didn't interrupt you.
Well, thank Julie Warnow, our wonderful reporter, for that.
But I like how you put that, and it goes back to our conversation about empathy, where when you see yourself in the data, that is approaching the data with empathy, and that allows the audience to see themselves in those numbers. And I think that's key when it comes to meeting people where they are as well. I would love to open this conversation up to our audience now. We have about 14 minutes for questions, and I know we have microphones available. I'll start on this side of the room and work my way over. Here in the front, Audrey.
Thank you. Thank you. Audrey Davis, Cancer Support Community. We have a few different programs that are also really good examples of pairing past clinical trial participants from the Black and African American community, from rural communities, from the Hispanic and Latino community, and then them having conversations with other cancer patients, because when you have cancer, you really do want to hear from someone who's been through it, especially if you're considering being in a clinical trial. That's my comment and example, but my question for you is actually related to algorithmic bias in AI, and for communities who have been both historically and contemporarily mistreated, who have mistrust that is founded in experiences and in their parents' and grandparents' experiences. What are we doing to address algorithmic bias that has been built into AI?
Yeah, within Google and certainly in the Google Health team, there's a team that's been working a lot on issues around understanding what this means for communities in a lot of different ways, and this idea of concepts around equity and the concepts around dealing with these things. So I will say that certainly that is an ongoing thought and concept and put into practice in terms of how the work is being done. It's not on my team, but it's a team led by a doctor by the name of Heather Colos, who's doing amazing work. That being said and done, these concepts will always take ongoing thought, effort, and because they're historic in nature. I mean, if you look back not just to the 60s, 50s, 40s, of the initial set of even data we started collecting around public health have always been infused with many of the challenges around access and bias. And so these are not new issues, they're historical in nature. And I think what is important is having the the thoughts and the leadership involved in having people at the table as much of these programmatic activities and other related stuff is unfolding.
Lisa, we heard Garth mention the work that you've done. Let's pass the mic to Lisa.
Morning, thank you. I really appreciate this conversation. My question is about, actually I can't read my handwriting, sorry. This is doctor handwriting. I am, yes. It's about how we better support people to discern misinformation. I interview a lot of people about this, and there's a woman I interviewed a few years ago. She consumes social media all day. This is where she gets all of her information. And I said, well, how can you tell if the information is true or not? And she said, well, if they have a lot of likes. Because if you have a lot of likes, you must know what you're talking about. So I would love to get your reaction. Given I understand there are some free speech implications here, but I would like to hear how you think we need to handle this. And then the second one is about this conversation, translating data and science for the kitchen table or the bus stop. It feels like that is not credible among policymakers and funders and people who make decisions. So what is your reaction to that as well?
I'll share one thought on the social media issue, which is, I think people should consider, when I say earlier, consider the source, but also, are they being transparent about the sources of their information? I think you should not really consider anybody that is not telling you where they're getting their information. If they're just saying it, and they're an influencer, they're probably being paid. But if they can cite sources, and I come at this from the perspective of a journalist, where that is core to our work, is to cite our sources and attribute. And if nobody is attributing the information, then I don't think that you could consider them trustworthy.
Yeah, and I'll just take that real quick, Lisa, too. The impetus, the description you just gave is why why we have on our platform, why we label health information, and whether it's coming again from an accredited source versus a doctor in general. And so one of the things that before we did stuff like this, that we found, similar to what you said around lights, people would say, well, I trust it because it was in a white coat. And so what we've done is to do the additional step to say, well, is this a licensed professional? And here is where you'll see that. And that is just one of many potential cues that people might have. The other thing I was going to say is, you think about that not just in the context of the US, but it's fascinating when you start to take it globally. And you start to think about this idea of licensure as a very more universal concept. And if I go to see you as a patient, if I go to see you as a clinician, I want to know that you've licensed. And so that's where we started with that step as a fundamental building block, because it's a concept that's universal in healthcare around the world, and it's something that patients can relate to. But that to us was a starting point for that very reason that you just said, is that people look for cues and clues. One of the things that you said in an earlier conversation is, everybody wants to make the right decision for themselves. No one is actively thinking, but you know what, I want to look at something that's wrong, and that's what I want to use. So everyone's starting off with that premise. So the question is, how do we help them along in that journey more than anything else?
Yeah. So what comment on the credibility issue around relatable information?
Actually, yes, sorry. Thank you for saying that point. That's another important point. So I think there's a baseline of this concept of qualifications. But again, this empathy and real life experiences and personal experience. Edelman, this is yearly Edelman's report about trust in healthcare, et cetera. And they did this interesting breakdown around what would make you trust somebody even more when they're presenting information online. And the number one thing from that report, and I'll say it in a different way, is, do you have empathy? Do you understand my lived experience? And so this idea, again, it starts with a baseline around, I think, evidence and qualifications. But I think the real crux, the real thing that matters is, how much do you understand my journey? How much do you understand me? And I'm going to look for people of a variety of different sources, and I'm going to resonate with the person who best reflects who I think I am. And so we have to think through that concept more, particularly and again, doing that around the world, amazing to see that. Amazing to see how this unfolds in so many, in Brazil, in Sao Paulo, and in all these different countries. And it's just an interesting concept.
And Lisa, I appreciate your question because I think just anecdotally, we are seeing a shift in trust where people will view information as more credible if the source has more likes or more followers. I don't know if we have data showing that or data showing how people gauge trust when they are consuming information on social media, but Poppy, have you seen any data in this space just when it comes to social media consumption and trust?
I mean, I will say our State of the Facts poll showed, similar to the data you were sharing, that social media is the first place people go for information, but it is the least trusted source. And so they do trust more national news, local news, and the post that really popped for us is when we make it personal, when we relate it to people's lived experiences, and that can just look like going from, well, here are vaccination rates overall for the country, to like, here are vaccination rates by state, so that people can see, how does their state compare? Is that out of the norm or in the norm, or looking at vaccination trends over time. So I think trying to put some context around it and get it as personal as possible is where we see our posts really pop.
Yeah. And we have about 5 minutes left for questions. We have one in the front here, Brianna. Oh, the microphone's coming.
Thank you. Hi, my name is Brianna. I'm currently a PhD candidate at Virginia Tech. I also was getting my MPH when everyone didn't know what public health was. Then they liked us and they hated us. That being said, I definitely have my own opinions about what public health could have done better during the pandemic. However, we also know that people were turning to social media or the news to also consume and understand what's going on. Should I get vaccinated? So hindsight's 2020. What could the media have done better in order to kind of combat the COVID-19 pandemic, whether that's information, misinformation, disinformation? Kind of going off of your point, my pop is in Eastern North Carolina, and he is very country, and he used to say, I'm not gonna listen to the white man on TV to get vaccinated. And I'm like, sir, you're in your 80s. Please get vaccinated and wear a mask. So I would just love to know, what could have the media have done a little bit better?
Gee, I guess that's for me. I covered the pandemic. We were in the thick of it at the time. And I think what I recall is the fog of war. It was it was a very confusing time. We were talking to epidemiologists and virologists and public health experts all the time. And they would say, we don't really know what's going on, we need more information. And I kept saying to reporters at the time, like, that's not going to be helpful to the reader to say, well, I don't know, we need more information. We need to find some way to give people something that they can take away. And that was a real struggle because there was not a lot of really reliable information. And as things started to emerge and we started to finally figure out a few things about the virus that we could find purchase on, we did start to be able to write a little bit more concrete stories. Like, you know what? It's ventilation. It's not the fomites on the surfaces. It is the aerosols. In looking back, should we have done more to acknowledge, but we don't know. I think we did plenty of that, but I can only speak for what we did at the Wall Street Journal. I think we were as responsible as we could at the time with the information that we had. I think that the challenge of terms of how we look back now is more a narrative that is being spun about what the public health officials said at the time. And they also were working with imperfect information, I think, and trying to think about how to save lives. They probably didn't think enough about the economy and social issues because that wasn't necessarily always their job. Their job was to save lives. It's hard to look back and say what we could have done different in the time when we had so little information and we were struggling with it ourselves. But I think, the public health officials themselves probably could have themselves said a little bit more publicly that it was a little bit unclear what was going on.
And I would say the same when, I think about the work that we did at CNN. But just in general, I also think that at that time, during the pandemic, it was so important to meet people where they are. Going back to the conversation we're having today, and also putting human faces to every death, every hospitalization, and also showing different faces, having your viewers see themselves in either those who are sick, or see themselves in those who are tracking the data, or see themselves in the physicians who are treating patients, so that you give this sense of, as a society, we're all in this together. And I think when you break down that wall and you show the humanity during a crisis, that's when you reach and empower your audience. I think we do have more questions. Oh, here in the middle. I think we can just go to that table and pass the mic around.
Our table wants to participate. Mary Woolley with Research America. So I just want to put out a thought here that, and it goes to meeting the moment and to the licensed professional concept. What if it were a requirement for licensing the professional that they were proficient in meeting the moment? What does that mean? That means in training of physicians, public health professionals of all kinds, basic scientists, that they learn in a structured way, like they learn other things for their career. They learn about the public context of their work going forward. What if we could do that?
I'll actually point out something that I find fascinating that is being done at Stony Brook University. Alan Alda, who you all know, in his later years has taken on a whole new mission, which to do exactly what you're describing, to teach scientists how to communicate to the public. And he's heads a whole institute there, and he's not as well as he used to be. But there are definitely efforts at universities to try to teach. There's a recognition, I think, in a lot of medical schools and universities that scientists and physicians need to understand how to communicate. And I actually kind of find that program of his fascinating. He also even runs an improv program using on-stage improv to teach scientists how to take questions and figure out how to quickly communicate answers. I don't know if improv is the answer writ large, but there are efforts to do it. I'm aware of, and you may know of more.
Yeah, there definitely are, and there's a lot of great minds, some in this room, that have plans along those lines. And Mary, you're always a visionary in terms of thinking through these things. So I'll just say that there's a lot underway, because I think people recognize that science for science sake is good, science for the community's sake is even better. So a lot of that, I think, is unfolding, as we speak.
And maybe just one more question at that table as our final question.
Thank you, Mary, for that plug. I'm Megan Ranney. I'm the Dean of the Yale School of Public Health, and this is something that we're actively working on. But I actually have a question around kind of the data. I'll say that we've actually been working to try to we have a publicly available website now that brings together electronic health record data, Google search data, wastewater data, existing CDC data. You can go to pophive.org and see it if you want. But I'm curious about what data sources you would want to see. So you talked about kind of that need for the publicly available data. All of us during COVID had our own favorite sources. Many of the major news organizations stood up sites, right, where you were calling public health officials every week to try to get updated numbers. What data sources would you want to see included that would be useful to you guys?
I'll just jump in and I'd say, to your point, I think the more local the data, the better. So I think strengthening local and county data infrastructure is key.
I'd agree with that. Local data and then demographics.
And in the kind of data that is the hardest to find, which is how care is paid for.
Thank you for that question, Dr. Rainey. And I thank you, panelists, for this wonderful discussion today. Thank you for joining our conversation, and enjoy the rest of your time here in Aspen.
Thank you.